Buongiorno a tutti.
Good morning. Francesca and I will be illustrating some very preliminary findings based on the Residras register, which is the Italian National Register of Dravet syndrome and PCDH19 and other SCN1A correlated mutation correlated diseases. And this is the result of the work of Dravet Italia, a not-for-profit organization which aimed to develop a registry, which is a tool to collect in a systematic fashion all of the key data of affected patients, genetic data, type of onset of the disease, clinical, neurological, neuropsychological, and instrumental data, with MRI imaging data and some key findings from the EEGs. The aim is to collect data for Dravet syndrome, but we immediately decided to include PCDH19 as well. And there is, amongst the other items, the definition of cluster seizures, so as to include these patients as well, and their data, obviously. We then spread this to all of the centers indicated in this map in northern and southern Italy. These are the accredited centers where physicians treating these patients can enter their data. We have 442 cases registered, 55 of which are PCDH19 patients. All females, and these are the centers that have been accredited and who have entered data on their PCDH19 patients. As you can see, there are many centers, and this has enabled us to collect all of this data. Obviously, we know that the estimate of the patient population in Italy is much larger, so we're hoping to see an increase in the number of accredited centers with the inclusion of new patients on the part of the accredited centers as well. So, these 55 female patients are equally distributed in northern and southern Italy. The genetic data have been entered, but it's very hard to have a systematic approach. We have details on 53 patients, all with a mutation. One patient has a missense truncating deletion. Age at diagnosis, variable, because we also include the date of diagnosis. In 50% of patients, diagnosis occurred within 2 years from onset, but there's still a large number of patients for whom diagnosis was after 10 years of age. Here we see the key data on disease onset. In 75% of all patients, the onset is before the age of 1, between 6 and 12 months of age, whereas onset after the age of 2 is relatively uncommon. First seizure, in some girls with, in some girls without fever. But when onset was after the first year, it is more frequently the case that seizures come with fever. So, semiology at onset, and these are the limitations of our register, in fact. If on the one hand, the register gives us the possibility of analyzing systematically and longitudinally all patients because of what Dr. Giordano was saying earlier. One of the register's objectives is that once the centers are accredited, they should undertake to have the inclusion of at least one patient follow-up per year in terms of EEG, cognitive conditions, etc., in order to understand the natural history of the patient. And the other limitation is the distinction between convulsive status epilepticus and cluster seizures, and we don't have that possibility. If we look at the data, we can see that if we really want to focus on the correlation between long-term evolution and the early years of disease, we need to select patients in whom it is possible to have details on their entire clinical evolution so as to differentiate. The first seizure is described by the treating physician as generalized tonic-clonic in 50% of cases, and in a third of the patients, motor, non-motor focal. In 1/4 of all patients, there is a clustered seizure definition without any further details. At onset, there is delayed development in about 10% of all cases, and this is a snapshot at onset. Then we decided to try and provide a snapshot of all 55 patients at the most recent follow-up. But as you can see, average age of this population is 10, but we've got girls who are only 2, 3, and then adults at the other end of the range. And this is the limitation of such an approach. Epilepsy persists in over 50% of patients, and as indicated before, the incidence of epilepsy progressively decreases over time. Only one patient is untreated. Most are characterized by a polytherapy approach, and then Francesca will give us an age breakdown to illustrate the kind of treatment. At the most recent follow-up, we can confirm that there is a great variability in terms of cognitive functioning. Over half of patients have a normal, borderline, or mild condition, and this, of course, is quite a positive finding. With respect to behavioral disorders, the incidence of autistic symptoms is much lower in this group. Other behavioral disorders are reported. A positive disorder, attention deficit, OCD, and then we moved on to correlation analysis. This is a comparison between cognitive behavioral persistence of seizures data and the data relative to onset. As expected, delayed development upon onset is per se negative prognostic indication. 80% of these patients at follow-up are already characterized by moderate or severe cognitive deficit. The other important aspect that needs to be highlighted is that the condition and the well-being of the patient at the moment of onset is important. We don't, in fact, need a trigger in some severe cases, such as fever, to have the first seizure. And then we would like to confirm what Marina Trevisano said. Early onset of seizures per se is an unfavorable prognostic factor, both in terms of persistence of seizures and also the presence of a moderate severe cognitive deficit and behavioral disorders. In conclusion, we can confirm what was observed in this series of 61 patients, that early onset in subjects below the age of 6 months is characterized by poor cognitive outcome and higher risk of behavioral disorders. There is a correlation between early onset and seizure persistence. And lastly, afebrile seizures at onset are a negative prognostic factor for both cognitive and behavioral.